Hi everyone, and welcome to the Hemophilia Federation of America's State of the States webinar. My name is Sarah Shinkman. I am the Advocacy and Outreach Manager for HFA. Thank you so much for joining us on today's webinar. We'll be talking about where healthcare legislation stands around the country. We have Katie Verb, our Director of Policy and Government Relations, who will be guiding us through today's call. Before I turn it over to Katie, just a few notes in terms of the logistics for today. Feel free to ask questions using the question box to the right of the screen, or you can raise your hand in the toolbar and we will unmute your line. We will answer any questions at the end of the presentation, and feel free to also follow up with us afterward. Please note that all lines are muted. So again, if you do have a question, raise your hand and we'll make sure to unmute your line so you can ask it over the line. Thank you, and I'm going to turn it over to Katie.
Thanks, Sarah. Hi, everybody. My name is Katie Verb, and I am the Director of Policy and Government Relations here at HFA. Before we get started, I just want to say, given the results of the election last night, that HFA is monitoring everything that is happening and any possible changes that this means for the community, and we are really ready to continue to represent the community here in DC and fight for anything that we need to fight for in the coming years. So just wanted to let everybody know that we are on top of these developments and will continue to stand strong and support and represent the community. All right, so what are we going to cover today? There have been some developments recently in the states around preferred drug lists, and then I was going to talk a little bit about formularies because I know that that has come up a lot. I think step therapy is going to be a huge area of legislation in the states in 2017, so I wanted to go over what that is and also what non-medical switching is. Those two go hand in hand. Prior authorization is another area where we've seen a jump in legislation, and I think we're going to continue to see that in 2017. And then I wanted to go over what we've been seeing with our project calls. Calls has given us a really great opportunity to kind of take the temperature of the community and find out what types of things people with bleeding disorders are experiencing in their insurance, so it lets us know where we should focus our efforts. And then I was just going to go over a couple of things to consider when choosing an advocacy agenda. So as you're thinking about these bills and thinking about what you guys want to work on in 2017, just some things to consider there. So first off, preferred drug lists. PDLs, preferred drug list formularies, I think these are words that have been going around a lot lately. A preferred drug list is a tool that health plans use to manage costs by steering patients towards certain drugs and away from other drugs. So the drugs that they want to steer you towards are their preferred, and then they can also take the form of non-preferred or generic. Health plan will not pay for non-preferred drugs unless the prescribing doctor obtains prior authorization. PDLs intentionally restrict patient access to certain medications. So we are actually starting to see some of that form in private plans, and we are also seeing a preferred drug list form in Medicaid. In Medicaid, a PDL is a list of drugs that the state plan says that they will cover. So their preferred drug lists are the list of drugs that the state plan Medicaid will automatically cover. Anything that's not on a preferred drug list in the Medicaid space is a non-preferred drug, and those can be accessed via different procedures that vary by state. So the good news with preferred drug lists in Medicaid is that states do have to provide access to all FDA-approved products, but what they don't have to do is limit the amount of hoops that you have to jump through to get that access. So it just depends on, in some states it's as simple as getting a note from your doctor. In some states you have to go through something a little bit more intensive, and those decisions, those preferred drug list decisions, are made by state Medicaid directors. So we've seen a couple of states implement some of those. So what is the issue here? As I said, that we've seen some states implementing them, but HFA believes that preferred drug lists really do not have a place in managing a bleeding disorders treatment or trying to manage those costs. Clotting factors are complex biological products. They're not interchangeable, as we all know, and the decision of what of the proper product to be used should be made between a physician and a patient. The health plans are showing increased interest in PDLs and other utilization management tools, which leads me to the next issue that I was going to talk about. Step therapy and non-medical switching are some of the other tools that, once preferred drug lists are implemented, we start to see step therapy being used. So step therapy is a health plan may require patients to try to use a certain drug that's usually less expensive before they will allow them access to a more expensive product. So you really see it as a step. You have to start at step 1 before they'll let you get to step 2. In order to get to step 2, patients' doctors must show that the listed drug does not work for the patient or cause adverse effects. And those policies are called fail first. So what does failing mean for the bleeding disorders community? That's something that we are really keeping an eye on as these policies get implemented. I have not seen a direct report that step therapy has occurred yet, but our fear at HFA is that whenever new products come to market or products that treat the disease differently, whenever those products come to market, that's when you really start to see steps being made. Until now, you treated a bleeding disorder by replacing the protein, and that was it. There really wasn't another mechanism. Now, now that there's a longer acting product, or there's different products that will be on the market in the next few years that have different mechanisms,
Muted.
you can. We're afraid that we're going to start to see those types of steps implemented in plans. Patient groups have generally been successful in arguing that step therapy should be avoided, and so that's good, and we are going to continue to do that and to work with big coalitions in DC to try to get step therapy legislation in states that protects patients. Again, clotting factors are complex biological products, not interchangeable. We really don't believe that insurance companies should be making decisions that should be made between doctors and their patients. And then also what's that concept of what is a failure in the bleeding disorders community is really nerve-wracking, because failures can lead to repeated bleeds and joint damage and all of that. So the next issue that really ties in with step therapy is this concept of non-medical switching. And these two things are things that we are probably going to see work in tandem in some of the states. So you might see a step therapy bill and a non-medical switching bill, or one or the other. But non-medical switching basically is whenever a health plan forces a patient who is stable on an existing drug regimen to switch to a different product that have reasons completely unrelated to their health. So it's really, I mean, the term says what it is. It's an insurance company or a non-medical entity switching products or making a switch and making decisions for patients. They can do this by dropping drugs from formularies. They can do this by raising the out-of-pocket costs, but the end result is that patients are forced to switch, and that decision was made by someone other than their doctor. So HFA really is against non-medical switching. We believe that it can impact continuity of care, hurt patients, and interfere with that doctor-patient relationship. There's also been a couple of studies that show that non-medical switching typically has either a negative or, at best, neutral effect on healthcare, very rarely a positive effect. So we tend to make the argument when we are talking about this that even if insurance companies are trying to save money, they're really not going to, because at the end of the day, the effect is going to be most likely negative, maybe neutral, but probably not positive. We also believe that non-medical switching practices can discriminate against patients who have expensive conditions, because dropping coverage of a particular drug on a health plan discourages patients from signing up or actually remaining on that plan. So what's happening as legislatively? So some states have focused on ensuring that the process for developing PDLs is transparent and evidence-based. There is state legislation that can set standards for preferred drug lists or for state Medicaid programs, state employees, and health plans. But it generally cannot affect preferred drug lists for private health plans, unfortunately. State legislative efforts for step therapy. There are a number of state bills addressing step therapy that are designed to make sure that there are clear and consistent processes for getting exceptions from step therapy protocols. So typical bills will require the drug, the typical bill might require that health plans grant exceptions from step therapy when the required drug will cause harm or an adverse reaction, or the required drug can be expected to be ineffective for that particular patient. Maybe they've tried it already. Or the individual patient has already unsuccessfully tried the same drug, or the individual patient has previously satisfied the step therapy protocol for his other doctor. So that is what a typical bill looks like in step therapy. And so the legislative efforts around non-medical switching. This is a little bit of a different approach to step therapy, but this bans adverse changes during a plan year. So your health plan is bound to keep covering the medications that it promised to cover at the time patients signed up for coverage. So the interesting thing about these bills is that they can really be pursued outside of the healthcare space, and they can be pursued in states in committees that might have jurisdiction over contracts or over consumer protections, because they really look at the contract between a patient, that health insurance is a contract between a plan and a patient. So that is a really interesting way that these bills can be pursued in the states. And then while it doesn't ban using step therapy, but it does at the bare minimum allow patients to keep their product for a year while they may try to find a different plan that they're covered. It really ensures continuity of care for patients with complex chronic medical conditions. There's some recent legislation that I won't go through. I'm not going to read through all of this, but some states have already enacted laws: California, Illinois, Indiana, Kansas, West Virginia, Texas. Those states have some protections in the step therapy and non-medical switching space. In 2017, we are expecting to see bills introduced in Colorado, Florida, Illinois, Indiana, Maryland, Massachusetts, Minnesota, Nevada, New York, Virginia, and Washington. And we are actively working with coalitions, mostly led by the Arthritis Association. So if you're interested in pursuing some of this legislation in your state, feel free to contact us. We can get you set up with the appropriate local coalition that is also working on these issues. The next issue I wanted to go over is the prior authorization. Prior authorization is the process of prescription drugs and services. It's the process through which you get approval for for particular products and services. And in certain states, it can be lengthy and difficult to do. And we've actually seen a really big uptick in this issue with our patients. We've heard through project calls that a lot of patients are experiencing really abnormally long prior authorization times, and that can really impact their ability to access care. So we are hoping to see some bills in states that streamline this process, or the insurance commissioners can do this for the plans in their states. But some examples of what we like to see, some standardized criteria in the prior authorization space, is that all of the forms are uniform. So you don't have to do a different form for a different plan, and it really takes off a lot of the burden on treating physicians and their staff and HT have to fill out 10 million different forms. And then time periods for responses and for authorizations are really big in this area, and we would really like to see a 72-hour turnaround. If your plan is forcing you to seek prior authorization, you know, aside from the concept that we believe that prior authorization for drugs that treated inherited genetic disorder is an issue in and of itself, but if they're forcing you to do that, then they really need to turn it around in a short period of time. And then, again, if they're forcing you to do this, we would really like it to last for longer than a month. I think we all know that treating bleeding disorders it's not going to go away. You're going to need to treat it next month as well. So if we seek bills that institute time periods for authorization that last, hopefully, at best case, 6 months. And then also the ability to submit them electronically is a really big issue. So there are some states that already have prior authorization protection. So states that have electronic prior authorization laws are California, Iowa, Ohio.
Muted.
And that is basically, it makes the process electronic. And it helps prevent the lengthy back and forth communications with pharmacies and health plans, and gives quicker access to medication. Then there are states with uniform prior authorization laws. And there's that list there. And then there's pending legislation in New Jersey, New York, and Pennsylvania. So some states that we would like to see this process become electronic and more uniform. So the next issue I want to talk about is the concept of drug pricing transparency versus health plan transparency versus healthcare cost transparency. This I wanted just to highlight briefly because these were bills that were introduced a lot last year and a little bit this year, and just it can be really confusing, and so I just wanted to briefly go over what those are. So drug pricing transparency, transparency seems to be the buzzword of 2016. So if you are seeing these, I just want people to know what they are. Drug pricing transparency bills are legislation that requires certain drug makers to report costs that relate to development, production, distribution, administration. We've actually been seeing these being tacked onto specialty tier bills. That's not something, and that therefore we haven't seen a lot of those passed. So you might have heard about it there, but again, I just want to clarify this if we continue to see another uptick of this legislation in the future. And then health plan transparency bills are different from the drug pricing transparency bills, and those types of bills really just seek to make health plans be more transparent about what's covered. So some bills include that plans have to provide information about the items and services covered under their plan. They have to provide information about exclusions or limitations, or they have to provide information about the formulary, the tier structure, prescription drug list, the information about network or healthcare providers, and then information about cost sharing. So that's the health plan transparency. A lot of these bills in states are just kind of referred to in general as transparency bills. So we just want to make clear again as we move into 2017 that people really know the difference with what they're looking at and what they're being asked to advocate for or advocating for. And then the next thing is another type of bill that we've seen is this healthcare cost transparency. So this basically requires hospitals and other medical facilities to provide information relating to their costs. So they're all a little bit different. They're probably all referred to as a transparency bills, but again, there are different types. So just be very vigilant in knowing when you're knowing about these bills. So the next thing I wanted to go over is project calls. I wanted to let the community know what we have seen with that project. And just a little bit of information, because this, again, has really guided our efforts, our advocacy efforts, because we've been able to see what's really happening out there in the community. We launched Project Calls in 2015 to collect patient-centered data, and we wanted to know, we knew theoretically that all of these things were coming and that they are harmful to patients, but we really needed the data. We need the data when we're out there advocating. We need the data when we're in states And so Project Calls has really helped us do that, and we're really open with what we're seeing so the community can know that and use the data as well in their advocacy efforts. So what have we been seeing? This is just some demographic information. The diagnosis is pretty standard to what we would expect in the community, as well as the type of insurance. The other graph on here that's interesting is self-insured. One of the things that we learned from this is that we really have to do a lot more education on the differences between self-insured and fully insured plans, because while this graph says that 69% of people say they're not self-insured, we've found that a lot of people don't know whether or not they're self-insured. You might have a card that says Blue Cross Blue Shield, but the reality is that that is your plan administrator, not your insurance plan. And self-insured plans, just as a brief reminder, are when employers decide to bear the risk of insuring their employees themselves. So they put money away in a pot and then pay out claims through that pot, and then sometimes use a plan administrator in something like a Blue Cross or United. They don't go out to Blue Cross or United or the bigger plans and purchase insurance for their employees. They bear the risk themselves. So that's the difference there between self-insured and fully insured. And they are, because of this, they're exempt from, self-insured plans have to follow different rules under the Affordable Care Act. So I think we need to really increase the amount of education we do for our community, and then they're out there in the states what you can, educating your community there. So the top 3 issues that we have seen with Project Calls are that insurance companies have mandated patients to a pharmacy that is not meeting the patient's needs. Insurance companies are forced patients to go through a lengthy prior authorization process, and a participant was forced to fail on a product before being allowed to use the product of their choice. There's a caveat with number 3. That issue where we saw failing through this was not for a product that treats a bleeding disorder. It was for a product dealing with a comorbidity issue. So we don't have the data that we've seen step there be specifically for clotting factor. It was reported for a different issue, but still reported nonetheless. So these are the issues that we've seen. 29% of participants so far have said that they have just been denied coverage for a product or service. 11% of participants have said that they have had to receive an exception from their plan in order to get access to a product or service. 15% said that they are being mandated to a pharmacy that is not meeting, they believe that is not meeting their needs. 18% said that they had to go through lengthy prior authorization process. 15% said that the amount of money that they were being asked to pay for a product or a service would have caused them financial hardship. 4% said that they were seeking treatment through a provider, and that they found that that provider was out of network and that caused issues. And then 4% said that they experienced step therapy, and again, not specifically for clotting factor, but for other factors. And then we had the 4% saying other. So that's a big graph of what we are seeing through the project. So this is what patients are reporting. And then up to the left there, we see that about 50% of people have reported that they have some kind of specialty pharmacy mandate. So that doesn't say whether or not that pharmacy is meeting their needs. We just wanted to know what the trend was. Are we really seeing people being mandated to a specific pharmacy? And yes, we are. And then we were also looking for a trend in billing. I don't know whether or not your product is billed on the pharmacy or medical side can have an effect on preferred drug lists and tiering and all of that. So we wanted to see what the trend was there. And I think that was, we're not surprised that 43% don't know, because I think a lot of patients get bills and might not necessarily know where they're coming from. This next slide, though, is really the one that helps us advocate the most. You don't participate in Project Calls unless you have an issue with your insurance. This Project Calls is not about collecting just general insurance data. You really only use the program if you have had a problem. So of the problems that were reported on the last slide, 67% of people who have reported their issues to project calls, or 67% who are having insurance issues, are delaying care. They're not treating when they're supposed to. They're not going to see their providers when they're supposed to. And so that is really, before we started doing project calls, we theoretically knew that a lot of these policies were bad for patients, that lengthy prior authorization times cause delays in treatment for patients. We theoretically knew that step therapy can be bad for patients, but until we've had this data, we can really now say if you implement these policies, it leads to delayed care and patients are not doing what they're supposed to do to be taking care of their health, and that causes huge problems. And then the other graph here shows that in almost every single instance where something was denied or there was prior authorization or financial hardship, it was for a product over a service. So that really lets us know where our access issues lie. People might be able to access their providers, but if they can't get access to the product they need, then that really causes a big problem. So next, I just wanted to go over, there's a couple slides, just wanted to go over some things to consider when you're choosing the advocacy agenda. I've gone over a lot of issues that we're focused on and issues that we've seen, and so when you're out there trying to decide if you want to advocate for a bill, just some of the things to consider when doing that. So one of the things that we always take a look at HFA is, does this issue have a direct and immediate effect on patients with bleeding disorders in a state or federally, or just have the potential to affect them in the future? We obviously like to be very planful in what we're doing and make sure things don't happen, but if we're going to be working on something very heavily, is it immediately impacting patients is one of the things that is the main thing that we consider. And then next, is it good overall policy? Is it good pro-patient policy? Is it good, is the bill written well? Will it have positive effects? And try to just kind of, are there unforeseen effects? What types of groups support the issue and what are their arguments and positions? So are you looking at something that's supported entirely by a trade association that represents insurance companies? Are you looking at a bill that's really got a ton of patient support behind it? What are their arguments? And then again, who opposes it? Are you working on a bill that might be opposed by one group that you want to work with in the future? Those are the kinds of things that you have to consider, especially in states where the players, it's a smaller playing field and the players often remain the same. So, and then always looking at opposition always helps you prepare your arguments. So finding out what other people are saying is crucial. What the other side is saying is really crucial to help you develop your own arguments. So does the policy have the potential for unintended consequences that might be adverse to our advocacy goals? That's a big thing. I know it's really hard to predict, but it's something that you have to think about and ask about. And then another big issue I know for member organizations in the states is do you have enough resources to advocate for the issue? Whether you say that it's going to be a top priority or a secondary priority, do you have people? Do you have enough resources? Have you collected a good group of advocates? Have you collected enough volunteers? Do you have an advocacy committee? Do you have the resources to jump into this issue? It's also important to look at whether or not what you want to work on runs contrary to any of your other policy positions. So, you want to just make sure that you're not advocating something that really, politically or policy-wise is against another issue that you're talking about. And then a good thing to look at when you're thinking about an advocacy agenda is have other bleeding disorders groups in other states successfully pursued this type of legislation? If so, what are some of the hurdles they faced? And that's where your national organizations can really come in, and that's where HFA can help you, because we can let you know if other states have experienced this issue and help you through that challenge. So we're wrapping up here, but I just wanted to wanted to talk a little bit more about project calls. If you are having an issue with your insurance, or if you know community is having an issue with your insurance, please ask them to participate. It really is helpful in deciding, helping HFA decide what we can do, the materials we put together. When we found, that when we heard that the step therapy was being reported, even though it wasn't for clotting factor, we really rallied and looked at what we could do in that arena, and it's really been influencing our policy agenda, and it helps us know exactly what we need to be working on to affect the community. And then patients who participate get access to this patient insurance logbook, which is really, really handy. It has a ton of information about how to get an exception. It walks you through there was a very formal appeals process set in place. It walks you through that. And then there are logging pages with prompts, making sure that every time you talk to your insurance company, you're logging every interaction so you can keep a really accurate account of what's going on and what your issue is. And it helps keep your insurance company accountable for the things that they tell you. So if you want to get in touch with us, you can email us at projectcalls@hemophiliafed.org, or just go to projectcalls.org and participate in the survey. So please encourage people who are having issues to participate, because it's really, really important. All right, I've come to the end. Any questions? I think we can open it up for questions now.
Unmuted.
Thanks, Katie. As I mentioned at the beginning of the presentation, if you do have a question, feel free to raise your hand, and I can go ahead and unmute your line. And while we're waiting for folks to raise their hand, I did see that somebody just posed a comment that Families USA is doing a 30-minute webinar on how the election results will affect the healthcare system this afternoon. So thanks, Linda, for that comment.
I see that there is a question here for the slides. Those slides are at N50, so that was a total of 50 participants, and that was when that data set was collected. And we are collecting and publishing the data set every quarter, and so the next data set will have a higher N, but that is where that one was cut off for the second round of reporting out that we did.
Great, thanks, Katie. Any other questions from folks? And feel free to also submit them in the chat box, as others have done. Okay, so I'm not seeing anything else come in, but as a reminder to folks, if you're interested in getting in contact with us, do feel free to email us at advocacy@hemophiliafed.org. Oh, I see there's a question that's just come in about self-funded plans making their own rules. Katie, do you want to respond to that one?
Sure. I have to open the questions box. Can you read it to me, please?
Yeah, absolutely. So it says, self-funded plans can make their own rules, ? My plan authorized our medication for an entire year, for which I am totally grateful right now. Is there a way to figure out how long a plan will pre-authorize before signing up?
So unfortunately, no. And that really, if that's something that you're interested in, that really, that goes into that health plan transparency. And then again, that's one of the reasons that we're pursuing that, that non-medical switching legislation in states. So plans can't make those types of changes or can't suddenly make changes. But no, unfortunately, they're really, other than calling once you're signed up, it's really, really hard to find out that type of information, which is why some of the states have been proactive and are trying to introduce those health plan transparency bills. But.
Great, thanks for answering that, Katie. Anybody else? Okay, so I'm not seeing any other questions, and you can see on the slide Katie has presented her email address as well as the advocacy email. So please do feel free to get in touch with us. Thanks again for joining us on today's webinar. We really appreciate your time, and we look forward to a great year ahead. Thank you.